Thank you very much indeed, Mike, and it's a great pleasure to be here. I'm not sure if it's the most difficult job in the government or the safest job in the government, because there are no other ministers who are after it, but for me, it's, I said when I got the job, it's the biggest privilege of my life, and I feel that more passionately now after 18 months in the job than I've ever felt. And I want to thank everyone here for the tremendous support that you've given to some of the big changes that we've had in the NHS over the last 4 years in probably the most difficult and challenging circumstances in the NHS's history. One of the best bits of advice for my job, which wasn't given to me personally, but which I read, was from Bill Clinton, who said, politics is like working in a graveyard. There are lots of people underneath you, but they're not necessarily listening. And I think for an organisation of 1.3 million people like the NHS, that is something that's important for every health secretary to think about. But I think there is one bit of advice in all the debates that Mike alluded to about clinical commission. There is one bit of advice that the NHS really has listened to, and I am incredibly proud, and a lot of the people in this room are responsible for that, which is the great hope of clinical commissioning was that we would see more innovation happening at a local level than was possible under the old SHA and PCT structures. And we really have seen that. And I think it's incredibly exciting if you look at the reforms to end-of-life care that I've seen in Bath, if you look at the outcome-based commissioning for MSK in Bedfordshire, if you look at the mental health commissioning in City and Hackney, the primary care, extraordinary primary care progress that I've seen in Tower Hamlets and Camden. All across the country, we can see CCGs are using the powers and the freedoms they have to make big steps forward in commissioning. And I think that is really exciting. But I hope you don't mind me saying this, but I want to ask you to do even more going forward, because we've had a lot of debate, rightly, in the NHS in the last couple of years about standards of care in the wake of what happened at mid-staffs. And I think it's, the response inside the NHS to that has been absolutely magnificent. But perhaps it's also meant that we haven't recognised that, important though inspections are, commissioning is going to be as important, if not more important, if we're going to deliver the standards of care that we want, the comprehensive universal coverage for which the NHS is so famous across the world, and rightly so. And so I just want to talk to you a little bit about what I think the future of CCGs are. And for me, it's very simple, and for me this is the heart of what the reforms that set up CCGs were intended to do. We need CCGs to become accountable care organisations. We need CCGs to take responsibility for the entire delivery of healthcare for the populations that they represent, and to show the vision and leadership based on capitation funding that you would see in healthcare systems in Spain by Grupo Ribera Salud in Valencia, or by Kaiser Permanente or Group Health in the US. That insight as to the truly remarkable improvements in care that you can give from a truly integrated system, that is what is made possible by the establishment of CCGs. And in the last 2 years, there have been 4 very big changes that I think make that possible. And I'm sure there are others to come, but let me just run through what some of those changes are. Firstly, we are now, with the establishment of CCGs in a way that was never possible under the old PCTs, becoming a commissioning-led organisation. And the new inspection-led regimes, I think this is something that hasn't been picked up on, but part of the purpose of the new Chief Inspector of Hospitals, the new Chief Inspector of General Practice of Adult Social Care, part of the purpose of the transparency website on hospital safety that I launched yesterday, is to try and move the NHS away from its traditional culture of solving every problem with targets and money to a culture where the vast majority of improvement is driven by peer review and people actually having the data and the information as to how they're doing against their peers. And that is, I think, a much more productive way and actually a much more powerful way of driving change. You still have to step in when you have, hospitals with severely entrenched problems, and that's why the last year has seen more than 10% of hospitals in the country go into special measures. But from a commissioning point of view, rather than, as the old PCTs had, having to take responsibility for turning organisations round yourself, actually the openness and the transparency that we now have means that much of that work, much of that energy will come from inside the organisations themselves. And I think we're starting to see that now. The trust in special measures, I imagine most people here will know of a trust near them in special measures. And most people will attest that the changes in the last year have been incredibly quick and dramatic in a way that no one thought was possible. The special measures hospitals alone, just the 15 of them, that apart from the one that was announced this week, have hired 1,200 more nurses and 120 more doctors. And that change across the NHS, actually, we've hired 5,000 more hospital nurses in the last year. Without any target, without any money, without any instruction coming from me, hospitals have decided they want to do that. And I think that kind of change driven by clinicians who say we want to do this because it's the right thing for patients is a much better way going forward. And I think that really helps commissioners in your job. But it also brings with it a responsibility. Because now that the information is public, now that we can all see where the top performers are and where the issues are that need to be addressed, the public will also be asking you as commissioners, what are you doing to make sure that you commission safe, high-quality care with the best outcomes? And you will need to have that answer for the people that you commission for as well going forward. So that's the first change. Now, the second change is to do with primary care. And I think one of the most important things that Andrew Lansley did was decide that we're not just going to have clinical commissioning, but it's actually GPs that are going to be responsible for that clinical commissioning. And I hope we will now start to see, I think the story of the NHS in the last 20 to 30 years, despite mid-staffs, has been a really massive transformation, transformative improvement in the quality of hospital care. I think the challenge for the next 10 years in the NHS is to see as huge a transformation in the quality of out-of-hospital care. And we already had some big changes to the GP contract, which I think will help commissioners as you start thinking like accountable care organisations, the named GPs coming back for the over 75s. For the first time, the responsibility for GPs to deliver proactive care to the most vulnerable 2% of patients on their lists. And that, I think, is the first step in a much bigger change. But I recognise that general practice is one of the most pressured parts of the NHS. I recognise that GPs are working extremely hard, and I think CCGs need to show a leadership role in helping move general practice into a better place, because we depend on general practice going forward. And if we're going to transform the NHS in the way we all want to do, general practice is our biggest asset. We are lucky in this country that we're one of the few countries in the world where people don't, as their first port of call, want to go to hospital. They want to go to see their GP. And we've got to use that big asset, which I think we've undervalued. The second big change is the Better Care Fund. And this gives you a leadership role as CCGs in jointly commissioning social care with local authorities. And up and down the country, we are seeing discussions happening as a result of the Better Care Fund, which have never happened before. And I'd like to thank you all for the part that you've played in that. And for those discussions to be meaningful, we have to make sure that local authorities are spending the extra resources they get in a way that really makes a difference to the NHS, actually does reduce emergency admissions at hospitals, actually does save the NHS money. And we also need to make sure in the NHS we're doing things for our part that help the social care system, supporting people with long-term conditions so that we don't have such large growth in the number of people needing to go into residential care permanently when we are discharging people from hospital, for example. So it's a really important and exciting collaboration. And then the final really important change is what Simon Stevens announced as one of the first things when he became Chief Executive of NHS England, which is the opportunity to co-commission primary care with NHS England. And I'm delighted to read in the HSJ, which is where I get all my news as well, that 180 of the 211 CCGs have said that they want to be considered for co-commissioning. So think of the opportunity that CCGs now have for that leadership role as an accountable care organisation to commission secondary care, to co-commission social care and to co-commission primary care. You are in the driving seat to deliver a completely new vision for integrated care in your areas, and you have the powers and freedoms to do that in the way people at a local level have never had before. Clinical leadership, the chance to break down barriers. Many of you are already starting to use those freedoms, and I want to support you to do it. Just a final thing from me. I don't believe that this will work if I or any Secretary of State tells you what to do. The point about integration is that it's about really strong collaboration and strong relationships at a local level, and they can never be mandated from on high. But what I can do is tell you on the basis of the many CCGs and local authorities that I talk to, what I think some of the critical factors are that are going to make this big transition in CCGs to becoming accountable care organisations a success. And I want to give you just 4 things, if I may, which I think are just 4 really basic things which, without which we will not reach the potential that's possible, but with which I think anything is possible. And those 4 things are, first of all, we absolutely need to get to a stage where we are able in real time to track the total health and social care costs, including the social care system, primary care, secondary care, community care, for every single one of the individuals for which we are commissioning care in our areas. And that's a really big and profound change. But until we have that financial information, it won't be possible to work out how integrated care can both give better outcomes and also save money. And I think it's a sort of pipework type issue to make sure that you as CCGs can get that data, but it's really important that you get it. Secondly, we need to be able to share electronic health records across the entire system so that the patients feel that they are receiving integrated care. There are some great things going on in parts of the country. We have a big debt of gratitude to GPs for ignoring what the NHS asked of them centrally and setting up their own electronic health records 10 years ago and having nothing to do with connecting for health. Thank goodness you did that. That means we now have some of the best primary care records in the world, which we need to use as the basis for electronic health records that we use throughout the system. So that was my second. The third thing, which, without question, incredibly important, is the full involvement of the acute sector right from the start of this process. What everyone agrees in theory is that we need to transfer resources from secondary to out-of-hospital care, and the areas which involve acutes in that discussion find that there is the wholehearted support from hospitals to do that, because they also understand that's the way to give better services to their population. The areas that will have the big battles and fights are the areas that exclude their local acute hospitals from those discussions. And then the final thing is leadership. Leadership is going to be absolutely essential. It's really important that you are the people who have the vision and say, we are going to make this happen in our area, and this is our compelling vision. And it's not going to come from us, and it's difficult in the NHS because we've had a top-down culture for a very long time, but we need that local engagement, that local leadership. And let me just leave you, and some of you have heard me say this before, but My favourite motto for leaders comes from Churchill, who said that success is the ability to go from failure to failure without losing your enthusiasm. So please don't lose your enthusiasm. This is very new, and there will be lots of setbacks along the way. But if you want encouragement, remember that last week the Independent Commonwealth Fund based in Washington said that over the last 4 years the NHS has become the best healthcare system in the world of 11 major economies. In that period, we've jumped from 7th place to 1st place for patient-centred care. So although we are very open about the challenges we face in the world, we are already in many ways a world leader. And this is the chance to show the world that we're not resting on our laurels. We know there's a very big step forward that we can do, and we in the NHS are going to be the first to get there. Thank you very much indeed.
Thank you very much, Secretary of State. And I'm going to ask for some questions. We've got a brief chance of questions, but just 3 points very quickly. I think we totally welcome your emphasis on us being able to get the right whole patient data, because that's lacking, and we can't commission integrated care without it. And neither can we commission integrated care unless we've got both the primary care and the hospital and community budgets. So we welcome that. And perhaps most of all, your statement that CCGs are in the driving seat, because many times at this conference people have said, well, who really is calling the shots locally? And I think you've made that quite clear today. Thank you, Secretary of State. So next, 3 questions, one in the front there, one over there, and one 3 rows back. We'll have 3 at once, please.
Good afternoon, Secretary of State. Michael Holding from Pharmacy Voice.
Where's Michael? I can't see you.
Yeah.
There, right. Sorry, Michael, yes.
Sorry, Jeremy. Michael Holding, Pharmacy Voice. Welcome all you said. Disappointed that you didn't mention the 3rd largest profession, pharmacy, in anything you said, and that's not uncommon, sadly. What will it take to put those words in your mouth without us having to do it for you?
Okay, one question. Another one over here.
Oh, we're doing 3 at a time, are we?
Do 3 at a time. Is that all right?
Fine. Yes.
Yeah.
David Hogarth, Local Health Watch. I'm also running a befriending organisation in North Westminster. On April 30th, we saw some appalling pictures of care homes. All of those were discovered through cameras, either from relatives or from Panorama itself. Would you agree that the way forward to drag up the standard of care in care homes and home care as well is more cameras, and would you consider removing some of the barriers to which local authorities experience and the Care Quality Commission in placing cameras, particularly secret ones?
And if you hand the microphone to the person next to you as a 3rd question.
Roger Goss, Co-Director Patient Concern. Welcome to a fellow outlier. Yesterday, Chan Nagpal, courtesy of the Today programme, told us that GP surgeries were imploding, which I think he means disappearing up their own whatever, and we were all going to have to wait longer for appointments. Question, do you believe him, or is this just the BMA being the BMA and trying to give you a pain in the butt?
Right, thank you for the very direct question. I actually, I wouldn't use the words that Chand used, but I do agree there is huge pressure on general practice, and I think that the solution to this has to be to expand capacity in out-of-hospital care. Yes, in general practice, but also in district nursing and community services. I think this is going to be the solution. We have said from the centre that we are going to train 5,000 more GPs over the next few years, and another 5,000 other out-of-hospital community clinicians. What I don't think would work is if I do it in a kind of top-down way, saying that, you know, we're going to have this many GPs here and this many GPs there, because I think different CCGs will have different ways of delivering this. But I think the the sign of success of what I'm talking about will be much, much bigger capacity in primary care so that people don't have to wait longer. I am against a 48-hour or any target time for GPs to see people because I'm worried about the unintended consequence. I think 10 minutes is already too short for people with complex long-term conditions. Some of those people need 20 minutes, half an hour to be seen by their GPs. And I think if you put in a target when the capacity isn't there, then people who need longer appointments may find their appointments squeezed down to 8 minutes, 5 minutes, 3 minutes. And I think that could be a very dangerous unintended consequence. The second question, the gentleman next to you, just to remind me, it was about cameras. I would have absolutely no objection if there are barriers to the use of cameras. I'd have no objection to removing those, providing they're used with the consent of families and patients. But I think one of the advantages of the transparency agenda is, frankly, things that have probably happened in care homes for generations are coming to light, and I think that's healthy. But I do think we need to do it in a way that carries the public with us and not in a big brother way. And do you know, there was just those words I forgot to put in my speech, but they were there in my mind. Pharmacy, pharmacy, pharmacy is such an important part of the changes we need because we know that 1 in 7 visits to A&E departments could be avoided if someone went to a pharmacist. 1 in 11 GP appointments could be avoided. And I think they need to be part of the electronic health record revolution. I think if pharmacists could see, with people's permission, their prescription history, their medication record, then a lot of people would simply go to their pharmacist and they would be able to get a much better service. And I think it's a massively untapped resource. And we are very much planning to include pharmacists in the use of electronic health records.
So we've got time for just another quick 3 questions. Some people near the back, perhaps. Could we take the microphones further back? Yes, just where you are there. Just where you are there. There's somebody with a hand in there. Put your hand up a bit more. Just there.
Thank you, Secretary of State, for your fantastic speech. I'm 16-year-old. I'm a student. I was just thinking, in the past few changes that have been made to the NHS, we've seen the creation of many NHS bodies. Now, personally, I fear that this will lead to competition between NHS bodies, and as a result, the basic healthcare of patients will be ignored. Now, would you not agree that the creation of so many NHS bodies will actually lead to competition, and eventually the health of the patients will be ignored?
Okay, good question. And there's a hand up over there. And could we give one to the person with the hand up right behind you there? And if you could give your microphone to the person just over there. So two more just to end, yeah?
Yep. Mike Hobday from Macmillan Cancer Support. It's really good news for patients, Secretary of State, that 2 of your 4 priorities are about the sharing of data and information in the NHS. But for the last 15 months, information governance has turned to treacle and the data has stopped flowing. How can we help you sort that out?
And very final question over there.
Yes, hello, I'm Georgios. I work for the Northeast London Commissioning Support Unit, and you mentioned that future healthcare is now the responsibility of the CSU. So my question is, of the CCGs. So my question is, how do you view the role of the CSUs in helping the CCGs deliver this healthcare? Within the NHS, outside, and why? Thank you.
Well, let me take it. First of all, I think the CSUs do have a very important role. They have a professionalism and an experience in commissioning that is absolutely vital for many CCGs. But I think they are there to provide services for CCGs. And so, in the end, it is up to CCGs how they use those services. But I'm very clear in my mind that it's CCGs and in particular the GPs who run CCGs who are in the driving seat. But they do have an important role which links to the second question, which is in the sharing of data, because there are different rules to protect patient confidentiality, and CSUs have some permissions that CCGs don't have. Look, I want to remove that treacle too, and I am aware of it, and we have tried, for example, by making it, changing the GP contract, making it clear that all NHS organisations have a duty to share data when it's in the patient's interest and not just a duty to protect patient confidentiality, although they have that as well. But please let me know if there are any blockages that are still there, because this is something that we are trying to work through. And competition. I think there's good competition and bad competition. I'm not someone who believes that competition is intrinsically always bad. I think it is a very positive thing when, as we did yesterday, we release data that allows people to compare themselves to their peers, and we find that the reporting culture in hospitals varies significantly across the country, from hospitals that have extremely good reporting culture to hospitals that need to improve their reporting culture. And I think you know, comparing yourself to your peers can do a very good job. I don't think that we don't want a system where competition prevents the integration of services. And so the way I see it is that I think CCGs should choose the best people for the jobs they need to commission care from, and they should be open-minded about where that comes from. But then once that care is commissioned, it should be fully integrated with all the other people that are providing care, so that it's a completely seamless process for the patient, and that the information that they give to one care provider is passed on, so they don't have to repeat it constantly to other care providers. What I don't want is for us to close our eyes to how things happen in different countries, in different hospitals. You know, there are hospitals like Hinchingbrook, which is run by Circle, a private sector country, where we can learn a great deal from how they've run hospitals. There are NHS hospitals like Salford Royal that are is one of the safest hospitals in the world, which is an NHS hospital. And I think if we're going to be the best in the world, we have to be open to the best ideas wherever they come from. And actually, I think that is what is happening in the NHS. I think that's how CCGs think. I think the real problem, if I make this my last point, Mike, the real problem is actually the holders of my office, because if I, as a Conservative MP, say, you know, private sector good, public sector bad, the world thinks he's just doing that because for ideological reasons. He's not doing it for, you know, the patient interest. But if a Labour Secretary of State or Shadow Secretary of State says public sector good, private sector bad, then the public suspect exactly the same. It's not because of patients, it's because of his own ideological predisposition. So I think the great opportunity of these reforms is that we've taken that choice away from elected Secretaries of State and we've given it to GPs, accountable, but nonetheless given it to GPs at a local level so it can be a clinically led decision. Ladies and gentlemen, thank you for all you're doing. Please keep up the good work, and I want to support you every step of the way. Thank you very much.